make some jokes to fulfill the time.
Well, for those who are from SIOP, we hope you're if you're from Europe, we hope you join the SIOP meeting in Glasgow. Now I feel like a news producer. Yeah. All right, let's go. Hi, everyone. I hope everybody can hear me. It will be great to see you all with the cameras on, just to make sure that everybody's happy. This is our first webinar for the SIOP AI working group for 2026. There's plenty of more. And we're happy to start with a very, very hot topic that are currently on the table of many, many institutions in the field of AI, the pathology. How do you encounter pathology in AI and in pediatric oncology, or in general, how you validate? And for this particular reason, we brought Alex Loebel from Sheba Medical Center to introduce the topic and talk about it. After his presentation, we will have an open discussion with questions. So stay tuned, and if you have any questions, don't hesitate to ask. So Alex, the floor is yours.
Thank you very much. Let me share the presentation. Great. So I'm going to talk about an introduction to computational pathology. My name is Alexander Loebel, and I'm the head of the computational pathology research lab at Sheba. I would just say again that if you have a question even during the presentation, then please don't hesitate to ask. For me, it's always much easier to make sure that everyone understands everything even during the conversation. And so things that might be clear for me may be new for you. And then if you have a question, then just please ask. This is, by the way, not generative AI image. This is real image of a tissue that turned up to be in the shape of a dinosaur. So just for you to know that this is not Gen AI. This is the real thing. Great. So a few words about me. So I studied physics and math in undergrad, and then I did my PhD in biophysics at the Weizmann Institute of Science. I did my postdoc, and I was a senior fellow at the Ludwig Maximilian Universität in Munich. My focus at the time was computational neuroscience, so the interface of biology and mathematics and physics, but at a different topic than what I'm doing now. But it definitely prepared me for what I'm doing now. After my time in Munich, I returned to Israel, and I was a data scientist and an algorithm developer at several startups here in Israel. And for more than 2 years now, I'm leading the computational pathology lab at Sheba. Sheba is quite a unique place. It is the largest medical center in the Middle East. It is number 7 in the Newsweek World Best Hospital 2026, which is quite prestigious. And I can tell you from my time in Sheba, so again, I didn't know Sheba until 2 years ago. And for my time in Sheba, it is really from an AI, from algorithmic, from innovation, it is really an exciting place. It really is amazing how, although it's a medical center, there is a whole ecosystem of innovation. It has several organic startups that they start every year. And in 2024, they had 2 huge exits for a total valuation of $750 million, which is, again, not bad for a medical center. It also has numerous collaborations with startups around the world and with established companies like NVIDIA. And it is a world leader in the digitization of routine pathology, H&E, and immunohistochemistry slides. This is something that we're going to discuss more today. And it is a world leader in the integration of AI solution within the clinical workflow within the pathology institute at Sheba. This is something that I'm going to touch again at the end, just to connect the algorithmic aspects with the clinical aspects and where they meet and how can they meet inside of the workflow of the clinical workflow. ARC is the innovative branch of Sheba. It has many offices and collaboration with many hospitals around the world. And the idea is to export the knowledge of integrating innovation AI within medical centers and to share it with other medical centers around the world. So it collaborates with many hospitals and with many companies. And the idea is to create critical mass of companies that comes together under one roof. And then they can talk to each other, learn from each other, and so on, all with the idea of this health system and advance the innovation within the clinical setup. Questions until now, maybe? Okay, then perfect. Then we move on to the main topic of the conversation, which is what is pathology. So I'm guessing that many of you knows what it is. Then what is digital pathology? And then the last part is going to be about what is computational pathology, which is going to be the main take-home messages of this presentation. So what is pathology? You have a patient, he goes to a doctor, he says, I have headaches. The doctor sends him to do an MRI. The MRI finds that there might be a problem. Then there's a surgery, and there's a biopsy taken and goes into the lab. In the lab, the tissue or the specimen or the biopsy is pre-processed and prepared into this purple color tissue on a slide. And then the pathologist can have a look under the microscope and make a decision if it's the tumor or not, what kind of tumor, if it's glioma, if it's primary, if it's metastasis, and if they think it's glioma, then what type of glioma is it? Then there's the whole classification of the glioma, and the idea is that when you go down this classification diagnosis tree, it impacts the treatment that the patient is going to get. Now, this is the usual pathology workflow of making a diagnosis. At the top of this specific tree for glioma, there's the idea of whether the tumor of the patient has mutation in its IDH gene. Now, what is digital pathology? So you take the physical specimen. These days you have scanners, big scanners that can accept the specimen and turn the slides into images. Now the pathologist doesn't have to be to look at the specimen under the microscope. They can even look at this image in their home and make the decision about whether there's a tumor, whether to send it for subsequent test or not, just from the digital image. This is few examples of images of brain tissue, of breast tissue, and of lung tissue, the whole slide and some patch. So the scale of the patch is this is about zoom 20. It's about 128 micron over 128 micron. Now, what is computational digital pathology? So we all know that we have models today that can look at pictures of cats and dogs and tell you if it's a cat and tell you where the cat is or where the dog is inside of the image. So this is more like a classification task, whether the image of the tissue that you're looking at, whether it's a tumor or benign. I should say malignant or benign, not tumor or benign. And then the other kind of question is, where is the tumor and what type of tumor is it? And this is about like a high-level view of the architecture, that you have an image, it goes through some pre-processing, then features are extracted and turned into embeddings. And the embeddings are the transforming the image into a set of numbers that then the AI model can use and classify whether the image is a dog or a cat. Now, a similar architecture can be used to decide whether, or to diagnose or to classify whether a specific tissue of a glioma patient has IDH mutation or not, directly from the H&E slide. And it also allows us to explain what the model has done. So obviously in medicine, you just don't want to have the results. You also want to provide some certainty or provide some confidence for the clinicians, whether the model made the decision it made according to the relevant features, physiological features in the image. And in pathology these days, you have this idea of foundation model that I'm going to touch a bit later and expand on that a bit later on. So this is something that, for example, we did in the lab. So we had some data of glioma patients. Some of them, the tumor had positive IDH mutations, and some of them didn't have the mutation. Of course, from the H&E, the pathologist cannot say the status of the mutation. So there is an immunotest, and when it is positive, then you can see it on the left side, and this is how we know. And this is how we know that on the left side is the mutant, and on the right side is the wild type. The model correctly identified that the left side is mutant and the right side is wild type. And the dark purple here, this is not the H&E, this is the attention that the model have told me I'm looking here to make the decision. And what's very nice is that the immunostaining is overlap with what the model has told me I'm looking here. So again, this is an example of how a model that can predict the IDH mutation from the H&E without the immuno. Now the clinicians look at these images and you can say, aha, the model have looked exactly where the immuno have looked to tell me about the status of the IDH, of the mutation. So this is very nice. Another models that we have, so this is a bit more detailed view of the architecture that again, you have the slides on the left. We actually tile them into patches because the slides are very big. So the images of the slides are gigapixel, so they are very large. So what we usually do, we tile them into small patches, go into the foundation model, we get embeddings again. So each image is transformed into a set of numbers. And then we have an attention model that provides attention values. And in this task, we wanted to see if, so this is a tissue of lymph node that might have metastasis of breast cancer. So we wanted the model to classify whether the tissue is normal, so there is no metastasis, whether there is macrometastasis or micrometastasis. And this is, for example, the set of data that we had, and in green is the annotation of the clinicians, of the pathologist. In green is the metastasis area. The model correctly identified that this is a macrometastasis, and high and deep red says high attention, and kind of like pink colorish is like a low attention. And as you can see, there is a complete overlap between where the model has looked at on the tissue in order to make a decision and the annotation of the pathologist. In addition, what we can do, we can segment. So again, this is a different AI model that can segment the tissues into several morphological features. And again, you can see that in the segmentation, this deep purple completely overlap with the annotation of the pathologist. So we can say that this prototype is the tumor tissue. And now we can quantify how much of tumor or how much of the tissue is of the metastasis of the tumor of the breast cancer, and you can very accurately calculate or analyze whether this is macrometastasis, micrometastasis, and so on. And then you can also use this kind of analysis in order to identify the tumor microenvironment, which is very important in the diagnosis and prognosis of patients.
Alex, can I ask you something before you go on? Maybe for some of us that are not aware, what do you mean by a foundation model? Can you explain a bit more about the process?
Yes. So I have to say that Uri and I didn't train on this but a very good question, and this is exactly my next slides. So what is a foundation model? A foundation model is an AI model that learns the most informative condensed representation of inputs using self-supervised methods. So these are like very, very big words in AI, but the idea is that you have a model that can get inputs. They can be text, images, sounds, any other input, and then they transform the inputs into an informative condensed representation. We call them embeddings. Using self-supervised methods. So what does it mean? It means that the model sees a lot of images. In our case, a lot of pathology images. The model, we don't give information to the model whether it's a tumor, whether it's malignant, whether it's benign, whether it's lung, whether it's liver, brain. We don't tell them anything. Self-supervised learning means that all they need to do is to be able to replicate what they see in the images. And by doing so, they learn very deep properties of the features of what they see in the image. And what we get at the end is we get a very generalist model that can transform in a very good way what they see in a digital pathology slide and condense the properties, the morphological properties that they see in the slide into a set of numbers that then you can use for downstream tasks. So this is one of the biggest and best foundation models that we work with and that exist now. The model was trained on more than 100,000 slides. And it was here you can see on the right side, you can see that it was tested on more than 30 downstream tasks, and the performance was better than the models that existed before it. So what you see is you have one foundation model that you can then use it to train and to test on numerous problems in medicine, in pathology, in diagnosis, in prognosis, and the performance is much better. There are several foundation models since then that were published. One of them is from Microsoft Research. One of them is from a startup called Pathology. And there's the second version of this model. So there was Virchow 1. By now, there's already Virchow 2, and there is multimodals, foundation models already, and so on. So this is a big field now in digital pathology, and in fact, it has advanced already from there, which I'm going to mention again in a few slides. So again, what you can use, so what purpose you can use, or what task you can use these foundation models for. We talk about diagnostic and prognostic tasks over many organs and many types of cancers. You can also use it for segmentation, as I've shown you. So what you've seen here is the paper from 2024 that we use to segment the the metastasis at the lymph node that I've showed you a few slides before. You can also use it for the purpose of virtual proteomics directly from the H&E. So proteomics is a very important tool for research and for the clinical use and for the development of medicines, but they cost a lot of money. Imagine that you can, instead of having to go through the codex machines and pay a lot of money, you can do virtual codex directly from the H&E, and having foundation models definitely helps in this direction. And again, this is one of the usages. So this is a paper from a few weeks ago, how you can virtually stain proteomics biomarkers on directly from H&E slides. You can also develop PathChat. So not ChatGPT, but PathChat, which means that you can show this engine an image, a patch of H&E slide or immunohistochemistry, and then you can have a conversation with the engine about what is in the image. So this is a startup called Modular that was purchased by AstraZeneca a few weeks ago. So this is going to be is already a tool for pathologists and for students and for anyone who's interested in medicine. Very important. With foundation models, you can also build a model that can predict directly from the H&E a complete panel of more than 500 genetic sequencing results over many types of mutations, of genetic mutations for many types of cancer. So imagine that you don't have to pay a lot of money and wait a long time to get the results for your patient or for research. You can actually just take the H&E, put them in the model, and immediately get the full panel of genetic mutations. So this is another paper that was published not so long ago. And going from a single modality of H&E, now there are models, as I mentioned, of multimodal foundation models that also embeds DNA sequencing and RNA sequencing of the same patients already in the model. This is again to improve the predictions of the genetic mutations of the RNA transcriptomics, and so on. So until now, I was talking mainly about unimodal models. Another thing that I wanted to mention is about multimodal models. So imagine again that we are talking about the patient journey from the time that they visit at the clinicians. So imagine that instead of having to go through the surgery and the lab and the diagnosis and all the tests, you can directly from the MRI in this case already make an early diagnosis of if the tumor is benign or malignant. If it is glioma, then what kind of glioma? Maybe it's not primary, maybe it's a metastasis and so on. So answer all this question directly from the imaging. Non-invasive early diagnosis that actually skips over the whole pathology part. So this is, again, another kind of models that we are working on in my lab, that you have a pipeline of the, so at the training phase of the models, you have a pipeline of the radiology, you have a pipeline of the pathology. On the radiology side, you create embeddings of the, in this case, of the MRI image. Then you project them onto the shared space of the MRI and the pathology, and you want to connect the pathology and the MRI embeddings together in the shared space. So what does it mean? You have for the same patients the MRI results and the pathology results, and you want to make them closer to each other as much as possible. and further away from other patients. Now, in the inference, so the beauty of this model that you can do it for MRI of the brain, MRI of breast, and CT of lung. The architecture is very similar. So the details are different. So for example, for the CT of lung, you need a different model to extract the features out because it's CT, it's not MRI. But the architecture is very similar. Now, this was the training phase. At the training phase, you need both modalities, the MRI and the pathology. But at the inference phase, you only have the MRI. And then what you do is that you take the MRI, the scans of the patient, you put it into the radiology pipeline, you get the embedding, and then you go back to the shared space and you find what is the nearest pathology embedding for this new MRI embedding. And then you look at the pathology results of the closest pathology embeddings, and you hypothesize, so this is the hypothesis, that the pathology diagnosis of this patient is going to be similar to the pathology results of that patient, of the new patient, if we would have made the biopsy and the diagnosis and so on. So this is the idea of this multimodal approach. It is called learning with privileged information. This is like a technical term because it means that during the training, the model has the privileged information of the pathology, but not during the inference, or not when we have new patients. But the idea is that by having for the new patients only the radiology, you can still get good enough results and diagnosis already at the stage of radiology to maybe begin even treatment, that's the plan at least, already early enough at the stage of the radiology. Any questions about this? Because this is slightly complicated, but it's a good point to see if you have any questions. Good. And so then the last thing that I wanted to mention is that, okay, so I was talking about all these AI models and diagnostic and prognostic and foundation models, and they are very good to do in doing subtyping, in predicting the genetic mutations from the H&E and so on. But how do you work with that? Because none of those models have gone for FDA approval yet. So at Sheba, what we do is the following. You have the biopsy. So we collaborate with a startup, with an Israeli startup. They have a model that predicts specific biomarkers for patients with lung cancer directly from the H&E. Now, the usual patient journey is you have the biopsy, there's the slide, there's the image, the pathologist looks at the image, then you have the standard test panel to discover what biomarker status are. This usually takes 4 weeks. Then there's the decision on treatment. And this is the usual workflow that you had seen in hospitals. What we do in Sheba, we take the whole slide image of the patient. We send it to the company, to the startup company. There's a secure cloud where the model existed. So there is no problem of leakage of information of the patients to outside people. The model provides in 2 minutes. It provides the prediction whether there is some mutation or not, for example, in EGFR or in ALK or in ROS. So these are biomarkers that impacts the decision of the clinicians what treatment to give to the patient. So in 2 minutes, the pathologist gets the result. Then, of course, this model is not FDA approved. Instead of doing the standard panel that takes 4 weeks, we do a specific genetic test for the specific biomarker that we want to confirm. This takes about 2 hours. So in 2 hours and 2 minutes, we get an answer for biomarkers that impact the treatment instead of 4 weeks. Okay, so this is the pipeline, and this is how impactful it is on the workflow. And from our experience at Sheba, so we know. So we usually do this workflow for patients that require answers very fast. 1/3 of the patients would not survive the 4 weeks period. So having the answer as fast as possible is it's not a hyperbole, it is a matter of life and death. So having this early answer as fast as possible and to decide on treatment with the help of AI is critical for these patients. Again, so this is one way of introducing AI into the workflow inside hospitals. Yes, Uri.
I want to ask a question on behalf of countries who are lacking the contact to the startup. What of the things that you are currently showing are available to other countries, other centers around the world? Is there possible to collaborate on those kind of efforts to create a better foundation mode, to fine-tune better, to make the sample size high, wider, to tune the system to high variability of samples, which we know is necessary from like the program that was sold to AstraZeneca? Is it now only for AstraZeneca, or is it something that applicable to others?
So I think that again, so I want to separate between the commercialization of tools and the research aspects. So, for example, some of the foundation models were developed in academia. They are open source, and these are the ones that we are using, for example. Some are proprietary foundation models of startup companies that this is their way of making money. And so they collaborated with big hospitals that have shares maybe in the startup, or maybe they bought some data, and then they use it to develop a foundation model. That's with that foundation model, they build models like diagnostic models. Like, for example, here in this case, the startup that I mentioned is called Imagen. They have their data set that they paid for. They developed this model for predicting actionable biomarkers for lung cancer. So they have a model specifically for actionable biomarkers, and they provide it as a service. At Sheba, I think that, again, because there's collaboration between Sheba and the startup, obviously we have a preferred fee, but this is a service that they want to sell. And if you are a hospital and you want to have this very similar workflow in your hospital, then you need to contact like this company Imagen and get their and collaborate with them, either as a collaboration that, for example, you are a hospital. If you have digital slides that you can augment to the database of this company, then you can maybe do some exchange. I give you data to improve your models, and you give me some free access to your model for a certain period of time. So this could be like one, but again, I don't want to suggest any. So I'm not a representative of Imagen, so I don't know what they're going to do. But this is one avenue. Other avenues is research consortium of hospitals that create databases and collaborate with AI research group to develop their own models. So again, one of the biggest group is the group of Faisal Mahmoud. He's one of the leaders in computational pathology. So we are using in the lab many of his models, and he just released a model that he trained in the lab about a month ago of a foundation model that was augmented with transcriptomics data. So the idea is now that the embeddings that I get from this model are not only including the morphological aspects of the whole slide image of the patient, they also predict transcriptomics information of that patient. So this is like the next generation of foundation models. And that just came out like a month ago. So I think that I'm hoping that I answer your question. I think that there are several avenues of how to move forward. One of them, again, is collaborating with startups. One of them is to collaborating with research institutions. One of them is to just buy solutions as a service in order to introduce that into the workflow of your specific hospitals.
No, I think it's perfect to show a use case of how can you collaborate with startups, and how you can advance your hospital capability by doing so. But yeah, thanks.
Yeah, and of course another example that there's always the cost benefit. So for example, in Sheba, what they did, so they established the research group that I'm leading in computational pathology, so we can develop our own solutions that can be the service of Sheba. And in fact, this week or in the next few weeks, we're going to create a new startup that comes out of the Institute of Pathology, and the title or the main goal of this startup is to provide computational pathology as a service. So this is a startup from within Sheba that will provide digital pathology services to other clinicians around the world. So this is part, again, of this ecosystem of innovation and startups within Sheba as a medical center. So this is like another avenue. It costs more money. It requires a bit more effort. But if you are good at that, then in the long run, it provides the benefits that you are looking at. I think that this was okay. So this was my last slide. So the last slide is so there's the people in my lab. I will mention Professor Iris Barshak. She is the head of the Institute of Pathology, and she actually the visionary behind the digitization of the slides at Sheba already in 2000. So we started in 2019. The whole process started several years earlier. And this allows, for example, my lab to do all of the research that we are doing. By now, Sheba has about 2 million slides that have been digitized, because all routine specimen H&E and immunohistochemistry slides have been digitized since the end of 2019. By now, there are more than 2 million. This is a huge database that Sheba leverage for collaborating with startups, with companies, and for research within Sheba itself. We have many collaborators within Sheba. So, for example, we work on the multimodal for lung cancer, lung CT. So Professor Edith Marom, she's the head of the thoracic imaging section at the Sheba Medical Center. We have collaborations about modeling specific mutations with KRAS in the pancreas. So this is the lab of Talia Golan, and we have other collaborations within Sheba. We collaborate as well with other research groups in the world, including Faisal Mahmoud from the Dana-Farber Cancer Institute, Professor Chayed Greenspan from Tel Aviv. We just published, or we just sent to MICAI 2 papers. One of them is with the lab of Chayed Greenspan, and one of them is with the lab of Arik Shamir from Reichman. And we have a very tight collaboration with Professor Zohar Yachini from the Technion. And this is it. So thanks for your time and for your patience. And this is my email in case you want to contact me about, so we now have a Q&A, but if later on you want to contact me about collaborating, about data, about questions, AI questions, questions about integrating AI solution within the workflow, clinical workflow, anything about what is the bike I have at the back, anything, feel free to ask me. I'm here.
Thank you very much. Thank you very much for introducing these really important topics, especially now. Maybe now we can stop sharing, Alex, and then we can ask people who would like to ask questions. This is an open discussion, open question. You can ask from wherever you are in the world. Ask Alex as an AI pathology expert some questions that come into your head. Feel free to just jump in. Otherwise, we let Pablo ask questions. And yeah, there he is.
Yeah, I was waiting, but it was so exciting, the presentation. Thank you a lot, because for me, that I'm a dummy in this field, I understood everything, and now I think that I can take some of your home message to the most atheistic colleagues that I have for AI. So I have some questions just to be sure that I understand correctly. So from the pathology point of view, sometimes you change your results in cytology or in the biopsy, depending on the quality of the tinction that we have, the methoxylineoxin or the immunochemistry, depending of many technical issues. So I mean, how the model can afford this variability? This is one question. Well, I will have more, but this is the first one. Alex.
So I hope that I understood, and if not, we can do like a second round. So the point is that there is a big problem in digital pathology that AI model has a bias towards for example, the scanner that the tissue was scanned with, or maybe the staining. So H&E staining, it's like a recipe in the wet lab. It's like when you make a cake. Even if you have the same recipe, then the ingredients at different places are not the same. So the flour in France and the flour in Spain and the flour in Israel are not the same flour. So the result of the cake is not the same. So it's the same with staining. Scanners are different. So yes, there is definitely a bias in models. And this is something that there's a lot of research at. One of the papers that we submitted to MICAI like a few weeks ago is exactly about that. It's about how can we improve the generalization of foundation models that they won't be impacted by the staining or the scanners as much. So this is definitely, so like with many AI models, that you have a bias given the data that the model was training on. So the more diverse the data is, the better. But there are a lot more scanners in the world than the data that you can train a model with. So for example, even if the Faisal-Mahmoud model was trained on 100,000 slides, and the Virchow model was trained on 1 million slides, and the Imagen model that I was mentioned, the Israeli startup company, was trained on 1.5 million slides. They don't cover the whole space of staining and of scanners. So the solution is to find a way to train the models to ignore this issue. So for example, in the process of developing the project that I mentioned, we went to discuss with a pathologist, and she said, I see the difference because sometimes at Chiba we get tissues from other hospitals. And for confirmation of or for consultation of the diagnosis. And she said, I know that the staining was different, but as a human being, I don't care. I filter this out. I focus on the morphology to make my decision. It's not so easy to train models to do that. But it is something that, first of all, it is a known problem. And second of all, there is a lot of research done to try to improve this aspect.
Great, thank you. Thank you very much. And about results, do you have any results from this model of lung cancer? Because I think that the rationale of the validation, it was great. I think to have a real-time validation with a Sanger technique for the NGS. But do you have already some results that you can just talk about today
Yes,
of
yes.
this model?
So actually, there is, I didn't reference that paper, but I think like 2 months ago, 3 months ago, there was a follow-up paper. So the figure that I've shown about the workflow is from a paper when the workflow was introduced into Sheba. And by now, there is already a paper that kind of look at the validation. If I remember correctly the numbers, the model is accurate more than 95% of the time.
Wow, amazing.
Again, we get the prediction of the model for the status of the actionable biomarker. We confirm it with a specific genetic test, FDA-approved specific genetic test, and more than 95% of the time, the model is correct.
Amazing. And the last is not a question, it's a suggestion or a question for my colleagues, Uri and Friso. So, as I understand, we need a lot of images to make it to validate a good model, big data, and many centers, I'm aware that they are actually digitalizing their images. For example, in my hospital, they are doing so in the last years. So there is a space, or maybe we should create it inside of AI, where we can find these kind of startups that are and teams like yours that are working already with these models, and where we can give our images and work together in a project. So my question for all of you is there a place, or we should create it to find these people that are already working on it?
You ask me or you
Well,
ask?
also for you, but
I,
if there
I
is
can,
a no, maybe we have to find a place inside your to just
so
to
I
get
can,
these people.
so
But
I
the
can
concept, I think, Alex, I will can if we had money, we will create PSYOP foundation model. So we
So
will,
I want to,
yeah.
I want to say a few things. So one of them, feel free to contact. I can connect you with the relevant Sheba people. They could give you much information and many contacts, and they can shortcut your search. Okay, and so could be one possible avenue. Another avenue is you don't need to have your own foundation models. And the whole point of foundation models that exist already in there, so for example, the lab of Faisal Mahmoud, all what they do with a lot of money is to create foundation models for everyone to use. For example, in Sheba, the IDH mutation predictive model, you don't need a lot of data anymore. With 100 patients, you can create a model with more than 90% accuracy to do something that pathologists with more than 30 years of experience cannot do. Okay, so now that you have foundation models, you can download it from again, all you have to do is someone that knows a bit of AI, and with that you can collaborate as a hospital with the university. And then you do some collaboration. There's a PhD student that builds you something if you need something simpler. Of course, I will put an asterisk on that, because the whole point of having the companies like Imagen and so on is that they have the whole pipeline of developing the model and doing the regulatory work and providing access to the model by simple people in order to be able to use them. You may not want to do it within a hospital. Okay, as I mentioned, my lab within the hospital, it has costs and benefits. If you are a hospital and you don't want to deal with everything, it could be much simpler just to contact a startup and collaborate with them. So, for example, that you are an alpha site for validation. Okay. And then you win and they win. You get access to something that could help in the clinical workflow, and they get the validation that they need in order to get one day this model approved by the FDA and so on and so on.
Yeah, there is a question in the chat. Are you aware of any institution or startups consortium that works with artificial intelligence blood smear, specifically with leukemia?
I don't. So I know that they exist. I know that they exist, but since it's a bit off my focus, I don't know too much about them. But I do know that there is a lot of work that goes into actually. So I just saw. So there's a company in Italy that I've just seen. I'm not sure if it's published yet. I think it's published. So if anyone send me an email about send me an email about it, and I will try to get you the publication. It's about blood smears and about so it's a specific disease, but I can't remember which one it is. But they build a complete AI model approach, multimodal AI model approach for blood smears. But I don't have it at the top of my head, so just send me an email and I will try to figure this out.
I just put on the chat your email so people can take a look if they would like to hear more about this.
Perfect.
Any more questions? We'll be happy to hear from the crowd. We have plenty, and also plenty of ideas, but maybe anybody wants to ask anything. Don't be shy.
So, it's always like the same thing.
Yeah.
Either it was very, very clear or it was completely not clear.
No, but I think maybe there are people. Yeah, Frieza, did you first of all?
Oh yeah,
Frieza,
I would love
Frieza,
to ask a
Frieza
question.
managed to change his name, which is great.
Yeah, I think I used the wrong link. So my name is Friso Kalkoen from the Maxima in Utrecht, in the Netherlands. In the bigger picture, I think the WHO classifications have changed a lot over the last few years, going from indeed morphology to genetics. And it's a bit philosophical question, but will we change the WHO classification once more or multiple times in the future? And will the pathologist write this new WHO classification or an AI specialist finding novel associations? How are we going to proceed, and what are we going to do with this knowledge? Or are we going to stick with the classification we have for now?
So I think that, again, medicine works rightfully so in a very slow pace sometimes, or most of the times. At Sheba, I'm very happy that my research lab is embedded within the Institute of Pathology, because we need a pathologist. I'm not a doctor. I'm not a medical doctor. I'm not a clinician, and I'm happy with that. But we are conversing with the pathologist every day. Today, for example, we launched another project that has to do with bone marrow kind of biopsies, and we had the meeting, myself, the student who's going to work on the project, and the two pathologists who will escort us, and they actually came with the idea. And the conversation was really good, and it was actually amazing. They gave us the important aspects of the clinicians, and we have to take that into account when we develop the model. And then when we do error analysis, we're going to go back to the pathologist to try to understand why the model made error. And even if the model made the correct decision, they are the ones that can give me information whether the model was looking at the right places. This is why we have these attention maps that I showed you in one of the slides. So at the moment, I would say maybe for the next, again, it's very hard to predict, but I would say for the next 15, 20 years, I think that the pathologist will still be there. But definitely, like with many other things in life, I think that definitely AI agents could replace pathologists in many, many tasks. So if you see where AI is today and where AI was 5 years ago, there's a huge jump. And then if we make even linear projection into the future, then definitely I would believe that a lot of the work of pathologists would be much faster, much easier, much more accurate for the benefit of the patients. But I would believe that the pathologists of the future will be very different than the pathologists of today, in the same way that computer science students today, that they have Claude and ChatGPT and all of those tools, are very different than the computer scientists even from 3, 4, 5 years ago.
Will it be a human pathologist or not?
I don't know.
You don't know. That's a good. But I would like to ask on behalf of other countries. I don't know if people are, but if I work in a certain country and I would like, and pathologists are rare, I have the ability to do the biopsy, to do the slide, and to scan it. Is there a possibility that that some institution could work with other centers to get pathology results, validated pathology result?
So this is the whole. So one of the ideas of this AI solutions, and as I mentioned, we are embarking on a new startup here at Chiba, is exactly that. So if you have a hospital, you have biopsies, so you have surgeries, you have specimen, you prepare the biopsies, and you can even scan them. As soon as you have it as an image, you can send it. So the idea is that you can send it for consultation, confirmation, and diagnosis and prognosis at other locations. So again, what we do in Chiba now, we are collaborating with the startup. The model sits somewhere on the cloud. We upload the image, we get the results. You can do it from anywhere in the world. So it's not really so this kind of like I wouldn't call it like a business plan, but this kind of like a collaborative plan is definitely something that once you have the image, it's very easy.
I think this is 4 o'clock. This is the time to end.
So we have just a question about, well, thank you for the wonderful presentations. Is there any plan to validate those models in resource limited setting? What do you think the availability of those models with discounted price? I think that you resolved the question also with this open window to send images. And maybe it's also a question for the webinar in May about ethics and regulation, sending information across countries, isn't it, Uri?
Sorry. Yes. So what was the question again?
So the question was, is there any plan to validate those models in resource limited setting? And do you think the availability of those models with discounted price?
Again, I'm not talking about pricing and regulation and stuff. This is not my field. And there are many people in Chiba, and I'm guessing in every hospital, that have to deal with the regulation and the question of, for example, sending data from outside of the hospitals from different countries, because different countries have different rules and regulations. So this is something that has to be discussed by agreements between hospitals. So, for example, we are now collaborating with hospitals in Canada and in Europe. So there are legal agreements to solve exactly these problems. I'm dealing with the development of the models and so on. When it comes to validation, again, it depends for what purpose. if you are a company and you have a model that you think it's, even if it was trained on low amount of data, on small amount of data, then you can validate it with, over time, with other hospitals. Okay, so it's not important about the amount of data that you train the model with. It's more about the number of cases that, prospective cases, that you test your model on over time. So for example, as I mentioned, we started this validation of this lung cancer actionable biomarkers in 2022. And now we have, after 3 years, we have enough data to publish a paper about the validation, and then maybe even progress to improve the workflow and make it even better. I see that there's a question about in Uganda. Yes, exactly. So even in Shiba, we have what we call the Helsinki committee that has to approve all the, even the project in my lab. I has to get a pre-approval from the in-house Helsinki committee because I'm working on data from human patients. I have to emphasize I'm working on anonymous data. So I don't know the patient's name and their ID numbers and so on. All I get is the image of the slide. And that's it.
So I think that these questions are perfect for inviting you to the webinar about ethics and AI that we are going to hold on May. So Uri, if you want just to close the meeting and remember how it's going to be this webinar. Thank you,
Thanks,
Alex.
Alex, for a great presentation. Thank you for joining us, giving an hour of time. Thanks everybody for joining. Alex's email is on the chat. Feel free to reach out. Feel free to reach out to us. We have also a lot of thought about how we can help validate this, pathology with other low resources countries. How we can maybe do a matchmaking between startups to low resources country who can actually pick it up. It's just food for thought for us. Again, thank you everybody, and we hope to see you in the next webinar. Thanks, Alex.
Ciao.
Hi, thank you.
Okay, bye. I will close the meeting.